So psychoeducation is kind of throughout treatment. As I said earlier, we want to, in the first session, if we have some time, we want to spend a little bit of time educating the families about OCD, just to give them a sense of what they might be expecting, and also to work to reduce some of their anxiety about the illness or about the kids for when they come back for the next session. But it really depends in terms of how much psychoed you do, and when you do, it really depends on the specifics of the situation. We may also talk a little bit about some of the information I presented earlier, so we may talk again about some of the other factors related to OCD, a little bit more detail maybe about the causes of OCD or the course of OCD or some of the common features of OCD, again depending on the situation. But, and again, in terms of the detail or the complexity that we go into is also going to depend on the family and the family situation with that. I had one of the first families that we dealt with, the brain imaging slides that I showed. We presented those to the family, talked about OCD as a neurobiological condition, and we're showing these images of, the PET images of brain functioning, and saying OCD's related to these differing levels or degrees of dysfunction in these different kinds of brain areas. And we completely freaked the family out, who then thought their kid was like brain damaged. So you need to be a little bit careful in terms of what you say. A little bit is good, too much can go in the wrong direction. But after and then what we also do over the course of treatment is we may remind the kids about what we're doing. So when we're doing the exposures and all, bring them back to the models of psychoeducation that we talked about, the conceptualization of OCD, the habituation, and as kind of needed to make sure that they understand what we're doing. The next step in treatment is to develop a fear hierarchy. So remember again, OCD, exposure-based CBT is done in a reasonably graded fashion. So you want to start with the simpler, less severe symptoms first. And the reason for that is we want to give the child some initial success experiences. We want to get things started on a good foot, to give the child some confidence in his or her ability that they can master these symptoms, and then you work forward from there. The speed with which you go through the hierarchy, we'll talk about in a little bit, and that really depends on the child. So we basically develop a symptom hierarchy, or fear hierarchy, where we develop, to make a list of all of the symptoms. Typically, we can pull the symptoms from the PsyBox. Remember, the PsyBox has that very detailed checklist as part of the initial severity rating. So we oftentimes will use that checklist as a list of all the symptoms, and then we can supplement that or edit that as we go through with the child. So for each symptom, we're going to use a fear thermometer or an OCD thermometer to rate each symptom in terms of how difficult is this for you to do. Or if you weren't able to do this behavior, how hard would that be? So you can see this is just one that we've mocked up based on a few different patients that we've worked with, and they go from relatively easier to relatively more difficult. And I think in terms of the handouts that you have a copy of the OCD thermometer, correct? And you also have in the packet, you have a copy, and I don't know if you want to cut these in to the video or not, or however you want to do it, but you also have a copy of the COIS, the impact scale as well, and then some of the other forms we're going to talk about as we go farther on. So you want to make up a symptom hierarchy. It's one of the first cases that I treated was a boy that had indecision. His obsession was that he was afraid of saying the wrong thing. So he couldn't really answer. If I said, like, what was the rating? Was it a 6 or a 7? He couldn't tell me. And I said, is it between a 6 and 7? He goes, I think so, but I'm not really sure. And I was a little bit less experienced with OCD. It took 4 weeks to do the symptom hierarchy before I figured out, oh, this is one of your symptoms, isn't it? So you don't want to get too bogged down in this. I mean, because the symptom hierarchy is an organic thing. It's going to change, it's going to shift, it's going to morph. If you did a symptom hierarchy at 9 o'clock in the morning, and then with the same kid you did it at 5 o'clock in the afternoon, you'd probably find very different things. So the goal of the hierarchy is to try to identify a starting point for treatment, is really the primary goal. You want to pick a symptom that's not going to blow the kid away, that's not going to be way too difficult. And then there are other things that we use it for. I'm going to talk a little bit about how we use the symptom hierarchy in an ongoing fashion throughout treatment. But really, you want to get a general sense of the symptoms, try to find some reasonable starting point to do the first exposures. Some kids have one symptom that they come in with. Other kids, we've done like 4 pages of hierarchy. You don't need to do that. You really, you don't want to spend hours and hours doing this, but you do want to get a reasonable sense of kind of the lay of the land with regard to the different symptoms and some of the different severity ratings. So once we have done this, we select an initial symptom. We select an initial symptom to start with, and typically that's going to be something that's going to be concrete. It's going to be something that we can do in session, and it's going to be something that, again, that reasonably isn't too difficult. And this is to start doing the exposures. And again, the goal of the exposure is to break this negative reinforcement cycle. So we want to disengage the obsession from the compulsion, is what we want to do. We want to break this connection. And the exposure triggers the obsession. In the response prevention, ideally what we're going to do is we're going to encourage the child to not engage in the ritual, and that's how we do it. Now, you can't force the kids to do it. The first thing is you can't handcuff them to the chair and not let them do their symptom. So this needs to be a collaborative effort with the child and with the patient. The therapist always models the behavior first. So whatever we're going to do, the therapist needs to do first and needs to present it in a way, you can't go in shaking and terrified that oh my, okay, I'll go first, because what kind of message is that going to send to the kid? But it is okay to say, and we have said, under certain conditions, to be somewhat honest. This is kind of weird to do this. Yeah, it is a little bit creepy, isn't it? Even for me, it's a little bit creepy. But you know what? I'm going to do it because I know that even though it's creepy, that there's really nothing bad is going to happen. That it's just my OCD talking and telling me bad things are happening, but I know that really that doesn't make any sense. So you can be somewhat honest in your modeling, but you don't want to over-disclose that I'm terrified. God, I hope I don't get sick from doing this, because that's really going to negate the exposure. But you do go first, depending on what you're doing. As I said, we encourage the child to resist ritualizing. We assess the SUDS levels at frequent intervals. So we're going to want to map, if you remember those habituation curves, that the anxiety goes up and then comes down. We're actually going to be tracking. So every so often, we're going to ask the child where their SUDS rating is, and we're going to trace out that curve. And then what we can say is remember when I drew that out for you, your anxiety is going to go way up. It's going to be hard at first, but then if we wait long enough, your anxiety will come back down. Well, let's do that. And then when you're doing exposure, ideally you do get some kind of a rough similar pattern, so you can show the child it's working. So when the child's anxiety goes up and he's afraid, you can say, great, that treatment's working. That means we're doing it the right way, because remember, your anxiety goes up at first. So you're always giving him a benchmark that he can kind of refer back to, that, this is what's supposed to be happening. Again, as a way to try to help them through the exposure. Was there a question?
Yeah, it seems pretty obvious when you're preventing a behavior like washing your hands after they touch something contaminated, you're modeling the contamination and not washing your hands. But when the ritual is like to tap 3 times because they have a thought in their head, how do you model that?
We'll get to that. I'm going to go through a lot of examples. We'll spend some time going over that. But that's a good question. The key element of this is coming up with the exposures that are going to be relevant and address the kids' symptoms. And contamination is easy. And actually, let me repeat the question. The question is, developing an exposure for contamination fears and hand washing seems reasonably straightforward. But how do you develop exposures? What do you do for other symptoms, like having to tap a certain number of times, or other symptoms that may not be so readily obvious? Or even how do you deal with cognitive intrusions or obsessions that may not be directly tied to rituals? We'll talk about that. So we want to have the child not give in to the OCD, not do the ritual. We want to assess their anxiety, and we want to continue the exposure until the anxiety decreases at least a certain amount from the peak. Now, typically what you see is like 50% from the peak. This is really much more flexible. It really needs to be done on an individual basis. In some cases, we may want to maintain the anxiety, the increased anxiety over longer periods of time. In other conditions, the anxiety might drop very quickly, and I'm going to demonstrate, do a little bit of role playing and get a sense of what this might look like in practice. And then the key is to do as much exposure as you can during the session. We really want to do repeated exposures. What a lot of new therapists will do is they'll do one exposure. They'll say, okay, so let's make this straight. You know, where's your anxiety? It's at an 8. Okay. Where's your anxiety now? It's at a 6. Okay. Where's your anxiety now? I guess it's at a 4. That's great. I'll see you next week. That is not exposure-based therapy. And they'll say, and then we spent the rest of the time talking about other stuff. You know, it's like, that's not exposure-based cognitive behavior therapy. You should be devoting the majority of time to exposure, ideally or typically, in the session. Now, some sessions you do have to deal with other things, but we really want to spend a lot of time doing as much exposure as we can. And then we're going to graph the SUDS ratings. As I said, we'll graph the SUDS ratings on a sheet or whatever kinds of form that you have to demonstrate to the child that there is this kind of pattern that they may see. Now, the reason this is just a made-up graph, but it just demonstrates one thing is that the graphs are typically not smooth. You might have a jagged kind of a graph where the anxiety might spike for whatever reasons. A child might have a reminder or a thought as you're doing something that's going to spike the anxiety. This anxiety might go down quickly. It may stay up. And there's an infinite number of patterns that we'll see, and we'll talk a little bit more about those. So we talked about a number of different exposures. So an easy one to start with is if kids, oftentimes kids will say that they need to write, they need to keep their writing or their homework perfect. They have to copy over, erase and copy over because they're afraid that if there's one mistake, they're going to flunk or something bad will happen. So, I mean, writing is a really easy exposure to start with. It's a very concrete exposure. If the kid says it's a 10 and I'm afraid if I get one letter wrong, the world is going to be annihilated and I can't sleep at night because of this, you're not going to start with that symptom. But for many kids, if they say, yeah, it's something that bothers me somewhat, that is something that you might be able to start with. And we're going to start with it in kind of a very much of a graded fashion. But it's something that's concrete that you can do. It's very observable. It's easy to do in session. We may, a lot of kids that have this writing thing, one of the things that they need to do is they need to close all the loops in their writing. So like the O's and A's, they have to have like the O has to be a completely closed circle. You know, some people, if you write fast, you may not completely close everything. So it might be the initial, how many people have to do that? I'm just looking to see. Everyone like, really? That's OCD? Oh, I don't know. So I have sloppy writing, so that one doesn't bother me. Might be, can you write an A and leave it open a little bit? And that could be a starting exposure. Or can you write an O? Or can you write boat is a good word for that. Or can you write slightly crooked? Or slightly uneven. And you can start with one letter. What's the easiest thing that you could do? Or what's the easiest thing that you'd be able to tolerate in terms of this writing? And then you do that, and then you go on. And that illustrates one other point about doing the hierarchy. Each item on the hierarchy, once selected, is then broken down into another hierarchy. So writing crooked. We're going to make a hierarchy. Let's start with writing crooked. We're going to make a hierarchy of that. So tell me more about the writing crooked. Well, all my stuff needs to be straight on the line, and all the loops need to be the same length. Like when I do G's and I don't write cursive, whatever the letters have Y's, whatever else has loops, all need to be the same. And then the T's need to be straight, and the I needs to be exact. The dot needs to be exactly over the I. Okay. So what would be an easier part or a smaller part of that? Clearly, or some things need to be more perfect than others. Well, I mean, so for example, what if the dot was a little bit crooked on the eye? Well, that would bother me. Would that bother you as much as if the whole line was completely crooked? No, the whole line being crooked would be the worst thing. What would be the next worst thing after that? Well, maybe just one word that's kind of crooked or doesn't line up in a right way. Okay, what next? Well, maybe if the loops were open. What next? Well, it's maybe if the T wasn't crossed. What about different kinds of subjects? So if you're doing homework versus writing, say, a letter, the homework is the worst thing. What about if somebody calls and you have to write down a message? Is that easier? No, that's pretty hard because I'm afraid that if I write it down crooked, then my mom won't understand what it means. Well, is there something easier? Yeah, if I'm just like writing stuff for fun, that's not that hard for me. Okay, so you want to get a sense. So we've come up with like 10 or 12 hierarchy items right there that we can start with. So let's think of a place to start. Which one of these things do you think would be the easiest for you to do right now, just to practice on, to see if you could resist doing it? And I usually ask the kid. I mean, the kids know. What does your OCD tell you to do? So what would be the opposite thing to do? You think you can do it? Okay, let's do it. So refine with the child the symptom that you're going to work on by really breaking this down. So, and then you work with the kid. So what would be a good starting point? Do you want to start maybe writing a word and keeping the loops open a little bit? Maybe just a little bit open? And kids say, yeah, I think I can do that. So then we would start doing that. Okay, why don't you write to, the word to, T-O, and just leave the O open just a little bit. Okay. And so where's your anxiety? And then you monitor the anxiety. As the anxiety goes up, as it starts to come down, great. So what would be the next thing? Why don't you write the to with the loop open even more? Okay, why don't you write to now with the O looking more like a U, completely open? Okay, let's try the word boat. Why don't you write boat with the B-O-A-O and the A all open? And make it crooked. Okay, and actually make the cross on the T kind of crooked too. Okay, so why don't you write like a whole sentence? And do that. Copy a sentence out of this book. You can have them generate something, you can have them come up with something, or you can have them copy a sentence. Okay, so now I want you to write a paragraph, and I want you every line to be crooked in a different direction. So you see how we've picked one item on the hierarchy, and we've broken that down, and we're escalating the difficulty of this over time. And that we may do that over a period. That may take 5 minutes to do that. That may take 30 or 40 minutes to do that. And we'll kind of work our way up and through. Now, when you're doing the exposures, you don't want to do any reassurance. You don't want to give the child any reassurance. And you also want to ask, are you doing anything right now to make your OCD go away? Or to kind of make this exposure easier? Anything like any thoughts that you're thinking or something that you're saying to yourself? And you find sometime that the kids are doing things to bind their anxiety. They're saying, yeah, I'm going like as soon as I write it, I'm kind of mentally erasing it. And I'm saying, I'm saying, this doesn't count because I'm in the therapy session. Or I'm saying, I'm counting, 1, 2, 3, or doing another ritual, mental ritual, to make my anxiety go down. You really want to ask that question because sometimes kids do that. We've actually had kids that have been in treatment for 4 or 5 weeks and we're not getting any response and we can't figure out why, and they're saying, oh, I do it, but I'm just telling myself that it doesn't count. And they don't know, they're just doing it, they're undoing it. Or like washing. Oh, I'll wash my hands for like the 2 minutes, and then I run and I wash and then I contaminate myself, and then I sit for 2 minutes like you said, and then I run to the bathroom and wash my hands. We have other kids that we're doing exposures with, and at the end of the exposure we say, then we bring the parent in, and we'll say, okay, so I want you to go into the waiting room now, and I'm talking to Mom for a few minutes, and you don't wash your hands. Can you not wash your hands until you get home? And the kid says, okay, and he leaves the waiting room, and he leaves the therapy room, and the mom comes in, and we'll get a knock on the door, and one of the therapists will say, I just saw Billy run down the hall and run into the bathroom as fast as he could. He almost knocked me over. So the kids sometimes are trying, they're just holding it together, and then they're going to undo it as quickly as they can. So you got to monitor against all that. You can encourage the child. You say, you're doing great. This is really good, but you don't want to encourage them saying, don't worry, there's nothing to worry about. You don't want to say anything like that. And if they say something like, well, I'm afraid something bad is going to happen, you can say, well, what do you think is going to happen? I'm afraid that something bad's happening because I'm writing crooked. I'm going to do bad on school or something. You wouldn't want to, again, encourage them or provide reassurance. You could say, well, I guess there's only one way to find out, right? This is an experiment. So we couch the exposures as experiments to the kids. We basically say, you think if you don't do your ritual that some event, something bad is going to happen, or you're going to have, and something bad will happen, or you're going to have this bad feeling that's going to last for a really long time. There's only one way to, that's a hypothesis. There's only one way to check this hypothesis is to do the experiment. So oftentimes with kids that are old enough, we're going to couch these as experiments and say, let's see what happens.
So is the cognitive of CBT, is that mainly in the psychoeducational part of it? I mean, it doesn't sound like you're addressing the cognitions at all at that moment. It's all just exposure, right?
Yeah, and people do it differently. Some people provide cognitive statements or self-statements or coping statements, or they encourage the kids to challenge the validity of the fear during the exposure. Well, I know I'm not going to get sick because it's just my OCD talking, so I can touch this. Or they may say, it's going to be okay, it's going to be okay, I'm doing really good, I want to beat my OCD. You know, the other way to think about it is that the cognitive statements and the cognitive restructuring is really great, maybe not so great in the heat of an exposure. Because in the heat of an exposure, you really want the child to process what's going on, to process the fear. And it may be that we basically, you know, one way to think about exposure in terms of this experiment is, so let's trigger your fear that something bad is going to happen and see if it happens. And we don't really want to necessarily do anything that's going to interfere with that process. So I think a lot of the cognitive restructuring kind of takes place outside of the actual exposure. We do some of that. I mean, some of that you can do. And as the anxiety towards the tail end of the exposure, as the anxiety is coming down, you can kind of work with the child to maybe process the exposure cognitively by doing some of these things. But I think in some ways, at least for older kids, or kids that have kind of the cognitive capacity to understand what they're doing it and why they're doing it, you're probably going to want to challenge to try to make the exposure maybe a bit more difficult rather than a bit more easy. So if the child basically, if I say I want you to touch this coffee cup. The kid says, ooh, that's gross, I don't know where it's been. You say, well, you know, let's touch it and see what happens. You think you're going to get sick if there are germs on it, you know, then we'll find out. And the kid goes, ooh, but where did that coffee come from? And I say, you know, I mean, the appropriate answer would be like, I don't know. Are there germs on it? I don't know. You know, we'll see. Because you don't want to do something, if you say, oh, don't worry, it's just my cup, you know, nothing bad will happen, that plays into the obsession or the anxiogenic cognition. So you don't want to do anything that's going to interfere with the kid's ability to process. Then after the exposure, you can talk about it. And I might say, so what do we know about germs? You know, how long can germs live in air? You know, how many kids do you know that get sick from drinking, from touching coffee cups? We certainly do all that cognitive restructuring and trying to reshape the cognitions, but typically that's done kind of after the exposure has been completed.
And if a client has the fear that something that'll happen to a loved one if they do or they don't do something, and you're doing it in the office, I mean, aren't a lot of these things yet to be seen in their minds? Well, you know, my mom didn't die yet, but, you know, it's only been a minute since I've done it, and maybe she'll get cancer next week.
Right. Well, you can deal with some of that. Again, you can deal with some of the, maybe some cognitive restructuring that precedes the exposure to kind of talk about this, or after the exposure. And I mean, there are a number of ways to deal with that. One would be, so you think that if say this is crooked, your mom might die of cancer. Well, how many times have you seen something crooked that you haven't been able to fix? Every single thing you've ever seen, as long as you've had OCD, you've been able to fix. Even if it was something kind of far away, or you were running by, or people were there, or you couldn't do it, you've been able to do it. You've never, ever once in your life resisted the urge to do that compulsion. And what happened? Did your mom die of cancer? So it may not be, you do have some evidence that this may not actually come true. So now we're going to test it again. If somebody says, but it may happen in 10 years, again, a potential cognitive strategy for that would be, well, a lot of things may happen in 10 years. But how do you know that it's going to be related to this? Kind of learning how to tolerate uncertainty or deal with uncertainty. So you might need to talk about that and do some kind of cognitive restructuring around that. But you're right, because if the exposure, if the untoward event is way off in the distance, you're not going to necessarily be able to maintain the exposure until this event happens to that, which would then falsify the hypothesis. You said it would be 3 years. Your mom might die in 3 years, so come back in 3 years and a day and we'll see what happened. And the kid comes back in 3 years and a day, you can say, oh, I guess you were wrong. Okay, let's go to the next symptom on your hierarchy. That's not going to work. So you do need to kind of work around it. But when we do these exposures, again, by doing the psychoeducation. The psychoeducation in itself is a bit of the cognitive restructuring, because we're presenting a model for OCD that basically states that the fears that the child has, or the obsessions that you have, or the concerns, aren't grounded in reality. They're false alarms that are being generated. And so in some ways that serves to maybe negate some of, gives them some kind of a thing to fall back on. Well, I know that this fear is probably irrational, but I still feel anxious anyway. So we can make the attribution to the OCD. That's your OCD making you feel this way, not the fact that your mom is really going to die. But let's test it and see. So it is. I don't know if I'm directly answering your question. It's a little bit complicated in that sense. But we probably don't, in the heat of the exposure, want to be talking about the cognitive ramifications and trying to get the child to challenge the fears necessarily in a way that may serve to mitigate them. Because if you can explain the fears away in some ways, that does take away a little bit, perhaps, from the exposure. At least if we're challenging the child to do that. So the idea, again, with the exposures is to again, each item you break it down into a number of different steps, and then you work your way through those steps. This is one of our favorites, as well as having the kids jump into the garbage can, and we do that in clinic. And again, the therapists aren't always so crazy about this exposure, because we have kind of tall garbage cans, and there's all sorts of stuff. And the way they typically start would be like touching the edge of the garbage can with the finger, and then touching more, and then putting their hand in a little bit, and then just kind of like blindly putting their head in until they get stuff and pull stuff out. And then there's goop on their hands, and then they can rub it on their hands and their face and stuff like that. And we had a kid in clinic, a little kid, and it was about the size of the garbage can. And the exposure she found, she like jumped in the garbage can. I think we made sure that there wasn't like a lot of goopy stuff that would mess up her clothes, but she didn't know that. And so she's in the garbage can, just like this kid, only standing up. It was a taller garbage can. And the therapist went to get the mom to bring her in to the end to show her what she's doing. And the mom walks in, the kid's in the garbage can, go like, "Hi, Mom!" So sometimes it helps to explain to the parent. We'll talk about the parent piece. It helps explain to the parent before you do that. And then this is kind of the prototypic top of the hierarchy item, is eating off of the toilet, which you don't always need to do. Well, it depends on the kid's symptoms. But if you need to do it, you need to do it. So it depends on the child's hierarchy. And again, as the therapist, you want to model the appropriate behavior. So again, just wanted to talk a little bit about some, and we're going to role play a couple of exposures in a second as soon as I get through this part of the workshop. I want to talk a little bit about just some more recent thinking in terms of how to optimize the efficacy of exposures. And this is some work by Michelle Krask and colleagues, and other people have done some work in this area as well. And there's some evidence suggesting that within and between session habituation does not necessarily predict reduction in anxiety over time in adults. This has not been tested in children at all. But what really seems to be important is the amount of time that the that the individual is in a fear-eliciting situation, is in the exposure, and the more time while they're in the exposure, involved in whatever it is, so having this crooked, they're processing the fear, and the more time they're able to spend doing that and process this fear, that tends to lead to a better outcome. So when I said earlier, doing the exposure, the anxiety goes up and then comes down, and then you're done, that's not very much time actually spent processing the fear in the exposure. That's not going to lead to a good outcome. But doing as much exposure as you can, as many exposure trials as you can, is going to be more helpful. The other thing from this is that in terms to enhance the generalization and the efficacy of the exposures is going to be try to make them as real world as possible. So this might be exposing a number of hierarchy items at the same time, or being somewhat unpredictable in terms of the items you select from the hierarchy. You may not necessarily go up in lockstep fashion. Doing the exposures in a variety of different settings, all these things which may serve to enhance generalizability. Now, we're not going to start with that with kids. We're not just going to reach into the hat and pull out, oh, we're going to start with 10, your highest exposure, great. You don't want to do that because we don't really know the extent to which this applies to children. This has really been all adult work. But some of it does make sense, and for older kids, and maybe even elementary age kids under certain conditions, once you've been doing some exposures and you're working your way up the hierarchy, and the child is comfortable and the child is showing some benefit, there probably is some merit in terms of trying to combine different exposures, maybe kind of randomly select certain exposures for the child to engage in a little bit out of order, or certainly do things in different kinds of contexts or settings, which again obviously is going to lead to better generalization and perhaps better outcomes. The other thing that we do in treatment is we really want to focus kind of on the positives. A lot of times kids may come in, or the moms may come in, and maybe from our perspective they've had a great week, but one bad thing happened. So the parent will come in and say, she only did her homework 4 times this week. And we're going 4 times? That's great! Yay! And the mom's going, you said 5, she only did it 4 times. Or dad, I don't want to pick on moms, but so we really want to try to, what's one thing that you did? That's fantastic, that's really great. And even if the kid says, I didn't do anything on my OCD this week, did you at least think about doing anything? Yeah, I thought about it sometimes, but it was too hard. Well, that's something really good that you're thinking about it, so we're getting closer, and we're really going to work on that. And again, this is not specific to OCD, but always catching that one kernel, whatever that little, might be like an atom. One atom of something positive out of the billions of atoms in the week, and that's what we're going to focus on and try to build on. So we really want to kind of maintain some sense of positive and some sense of perspective. The other thing we do to deal with this is you should have this symptom hierarchy tracker sheet as well. So for the hierarchy, the symptom hierarchy, or the OCD hierarchy for the kids, what we tend to do is every couple of weeks, we want to re-rate the hierarchy. And there are different ways of doing this. There's a way of doing it where you take the entire session, it takes an hour, and you talk about each symptom, and the kid does everything, and you have no time for exposure, or you do it in 5 minutes. I prefer the 5-minute way. But it's hard to do, so I actually recommend, this is a really great exercise, but I hesitate to recommend it sometimes because it really can be done incorrectly and take up a lot of session time. So the best way to do it is you just, at the beginning of the session, after you kind of talk about the positives, how things are going, say, now let's re-rate the symptom hierarchy, and you give them a feeling thermometer. You say, I'm going to read each symptom. I just want you to give me the number where it is. We're not going to talk about it. Just give me the number where it is, and then we'll talk about it later. And you just go down. So checking schoolwork with your numbers straight. That was 3. Checking letters closed, blank spaces, doorknob. And you literally just spend a few minutes kind of going over and writing down the numbers. And typically what you'll find is the parent or the child might say, oh, I had a hard week. I don't think my OCD is getting any better. And then you look at the numbers and you can see that there is improvement. And sometimes if the kid says, what was my number last time? I'll tell them, they say, what was my number for bathroom last time? I say it's a 7, then they'll say, oh yeah, okay, I guess it's like a 5, or it's still a 7, or it's an 8, or whatever it is. But by doing this, it's nice because you can in most cases, the numbers do tend to shift downward, tend to get better. And you can provide that feedback to the child and the parent. So even if they come in and say, oh, it was a bad week, nothing's really going right, or this is really hard, I'm discouraged, you can say, well, look, this looks like you're getting better. And even though it's hard and there's other things in your life that are going on that are difficult, this looks like the treatment is starting to work and it's really good. And they can kind of say, oh, wow, I didn't really realize that. It can be really nice. The other thing that's nice about this is a lot of times kids are afraid to start treatment or afraid to tell you all of their symptoms because they're thinking about doing exposures to their most difficult symptom. So we're going to start with the threes. We're going to start with checking schoolwork. The kid's fixated on, there's no way I'm giving up my bedtime ritual, which is a 10 on this list. And I've had kids saying, I don't want to, they don't want to tell you their hardest symptom because they're just terrified. They can't even think about it, let alone say it. So what we do with this is you can see over time that you're going to see reduction in SUDS ratings for symptoms that haven't been addressed in treatment, maybe a little bit slower. So this is 6 weeks into treatment. You can see the bedtime ritual, just as an example, probably wouldn't have been addressed by that point, but it's dropped from a 10 to a 6. And that's why, if you think about OCD, what we're really doing is we're picking away at the conceptual framework, the framework of OCD in the child's mind or the child's experience. And we're gradually chipping away. First, we're starting with some of the little symptoms that are going to be easier to pick off, and gradually we're getting to more difficult symptoms. And the net effect is that the child, even if the child's able to handle some of the easier symptoms, that may have a positive effect on his or her thinking, because he or she can start challenging some of these thoughts. It's just my OCD talking, externalize, develop some confidence in the treatment. So this is kind of a nice exercise. And what we can tell kids is, as we're doing this, and we can say, see, some of these, even the hard symptoms might be getting a little bit better. So at the beginning of treatment, the child says, when I say we're going to do exposure, we're going to work our way up the list, the kid says, I'm never going to be able to do my 10. I'm never going to be able to do my hard stuff. You can say, you know what you may find? We'll wait and see. But sometimes with kids, even when we're working on the easier symptoms, the harder stuff actually starts getting not so hard. So by the time we get to your bedtime ritual, which is a 10 now, it may only be a 5 or a 6, and it'll be easier to work with. And so that's another good reason for doing this. The other thing is you might find that there's no change, or that symptoms are getting worse. And that's going to tell you, A, that there's either something wrong with your approach, or there's something going on with the kid's compliance, or that maybe the child is negating the exposures the way we described earlier. Like the kid's touching something contaminated, waiting 5 seconds, and then running to the bathroom and washing his or her hands, which negates the exposure. So it's really, if treatment's working, it's a really nice reinforcement for the child. If treatment's not working, this can let you know and alert you to the fact that something is going on. But I would really caution you that if you use this, you can't let it take the whole hour, because it's easy for kids to talk about their symptoms, and kids know that the more they talk, the less exposure they have to do. And they know it much better than the therapists do. So you absolutely have to be aware of that and to keep this reasonably compact in terms of the time that you do it. That brings up another issue that comes up in other ways, is that the kids like to talk sometimes. And a lot of times the kids want to avoid doing exposures, so they are going to either inadvertently, oftentimes it's not even purposefully, but with the therapist, when you have a therapist that isn't is experienced, and the kid comes in and starts talking about the symptoms, or how was your week, or how was your day. And oftentimes the therapists, especially less experienced therapists, are a little bit squeamish about doing exposures. They may not be that confident in their ability to do the exposures. So they're all too happy just to kind of talk to the child and kind of process what's going on with the child. How was your week? How are your symptoms? What was going on? And the child kind of says, well, I was at school, and it was hard for me I had to keep erasing my letters and rewriting again, and that was hard for me. And, oh, tell me more about that. It was really difficult, and I was trying to think about what I was doing the right thing, and they get into kind of the cognitive spiel, and before you know it, 40 minutes has gone by, and the whole exposure's gone, and it's a wasted opportunity. So it's really important to try to get as much exposure in, and you can certainly talk to the child and process with the child and the parent, but you really need to be careful it doesn't take the whole session. And sometimes the therapist will come out and say, this was a great therapy session. I learned so much about the OCD and we really have a great connection. And you say, yeah, but you didn't do any exposure. This is especially acute, and I fall into this trap sometimes too, with kids that have this need to tell or need to confess. How many of you guys have seen kids with OCD that they need to tell you their compulsion is, they're afraid they're going to forget or leave something out, so they have to tell you every detail. So you have this need to tell or confess that's driving the child to give you all of these details along with reassurance seeking. So they're telling you all about their day or their school, and they're waiting for you to say, great, oh, that's okay, or don't worry so much, and they're pulling for reassurance. And they're doing it very skillfully. Again, it's not necessarily purposeful, it's just kind of the child's style. It's kind of how they've evolved because of their OCD. So again, you find that you've gone the whole session or 40 minutes into the session, and you really haven't done any work. So it really is important that the exposure and response prevention is really the focus of the treatment.
Related to that, is there any personality type that tends to have OCD in kids, like intellectual kids, gifted kids? And I imagine that certain types of kids are more...
OCD comes in all flavors and all kids. I mean, verbal kids are might be more likely to verbalize. I mean, this. Anxious kids, the harm avoidance kids sometimes might be more reassurance seeking than kind of the just right kids, where it's more kind of, there's kind of more sensory OCD and affect or harm related OCD. But it's really hard to, there's not one.
Not a correlate there?
No, you just need to really be careful and be on top of things and look and kind of monitor yourself and your own anxiety about this. Just one anecdote. I heard at a talk a couple of years ago that I was a discussant for, and the presenter was talking about CBT and went to a hardware store and bought, like you can buy like the toilet cover, the seat and then the lid, for his brakes. And he went and he obtained one of those before the talk. And he walked up to the stage and I'm paraphrasing, grossly paraphrasing, and he picked up the toy stick and he said, and I think he put it around his neck, or he just touched it or rubbed it or something and said, how many of you would be willing to do this? And 3 out of 100 people raised their hand. And he goes, thank you, everybody else can now leave because this is not going to be of any benefit to you. And that's very true, because if you're not willing to do the exposures and you're not willing to stick your hand in the garbage, then there's no reason to do it because it won't work. I mean, it does take a certain level of self-reflection in terms of being able to do this kind of treatment. And you can certainly learn how to do it, but it requires, you're modeling to the child, and it requires a certain ability to be able to tolerate the stuff that you're asking the child to do, and to model this in a confident and informed way to the child that this is what needs to be done, and that you're going to do it with the child. So, in our clinic with less experienced therapists, we do have a number of therapists that are just not that comfortable with it, and they would rather talk and process and do the cognitive work without doing the exposure, and the treatment isn't going to be as effective. Was there another question? Yes.
I work primarily with younger kids, 0 to 5 years. So I'm wondering how to sell them, if they're working with a 3-4-year-old, how to engage them in the process, how to convince them they might be less motivated, I would imagine, to go along with it. Mm-hmm.
It's all done in the context of play. And can you remember that question? Because I'll talk about that next, and ask me again if I forget. Let's do a role play. So what I thought we could do today would be work on your contamination fear, okay? How's that good? Sure. Okay, so we talked about a few different things last session that you don't like contamination because you're afraid of germs and you're afraid that you might get sick. And you also just think touching stuff is kind of gross, right? Yeah. And then you have to wash your hands. Mm-hmm. Okay, good. So what I thought we could do is we could use this coffee cup among some other things. So what we're going to do is we're going to start very slow. And the first thing I want you to tell me is, do you remember why we do exposures? Why you're here and why we're going to do exposure?
Because you're mean.
Uh-huh, that's right. And why else?
It's going to help.
It'll help, right?
Yeah.
Okay. Because when you are afraid of touching this because of germs, is that, tell me a little bit more about OCD. So what's your OCD telling you that's going to happen if you, say, touch this cup as an example?
I'm gonna get cancer and die.
Uh-huh, okay. And that's something that you're afraid of?
Yeah, I don't want to die.
Uh-huh, okay. And do you remember we talked about OCD as sometimes being like a false alarm?
Mm-hmm.
Like it goes off even when things aren't dangerous?
Yeah, like a car alarm.
Uh-huh, yeah, that's right. Good. You're old enough to know what car alarms are. That's really good. So that's kind of something that we talked about, that we can do kind of like an experiment and see. And you said before sometimes you do have to touch things that are contaminated, right? And it's hard for you, right? It's really gross.
Yeah, I guess.
And you'd rather not, right?
Definitely not, no.
I mean, yeah, most people wouldn't want to touch stuff that's contaminated or gross or dirty or anything, right?
No.
But sometimes we have to. And by not ever doing any of that, that can have like kind of a negative impact on your life, right? Because you don't want to do certain things, or it kind of really gets in the way and makes you feel bad sometimes.
Mm-hmm.
So that's one of the reasons why we're doing this.
Yeah.
So what I thought we could do is we could start by doing something really, really, really easy, okay? What is something that you could touch that you think you would be able to touch without washing your hands? Anything around here. Doesn't even need to be the cup. Anything.
Probably touch my own shoe.
Okay, so why don't you try to do that? I'll touch mine first, okay? Where are you going to touch it?
Just like the top.
Okay, I'll do that too, okay? I'll go first, okay? Can you do that? Where's your anxiety rating? Remember your SUDS rating from 0 to 10? Where is that right now?
It's not too bad, maybe like 5.
Okay, where is it now after touching?
That wasn't too bad. It's
Okay.
been about 5.
Okay, was it easier than you thought?
Yeah,
Uh-huh,
it was pretty easy.
excellent. That's really good.
But I know my shoe's clean.
Okay, can you touch your shoe with 2 fingers?
I guess.
Okay, let's try that. Excellent. Okay, let's hold it there for a minute too, okay? Where's your anxiety now?
Yeah, it's like a 6.
It's going up?
Yeah.
Okay. Remember when we talked about when your OCD is triggered and your anxiety goes up?
Yeah.
And then what do you think is going to happen?
It's just going to get worse and I'm going to explode.
Uh-huh, okay. How long do you think it'll take for you to explode?
I think if I held it there for like a minute, I'd probably explode.
Okay, want to see?
No.
That's kind of an experiment, right?
I don't want to.
Okay. Do you think you might explode now anyway, since you can't wash your hands right now?
I don't know. Maybe.
Okay. Well, let's wait and see what happens, okay? I don't think you will.
Okay.
Have you ever touched anything before, just like walking down the street or something, and then you weren't able to wash your hands?
Yeah, I guess so. Maybe like by accident or...
Yeah, okay. How many times have you exploded?
I can't remember.
Uh-huh, okay.
Probably not.
Okay. But this might be the first time. There's always a first time, right?
It can happen.
Uh-huh. This would be the first time you exploded? Okay. Where's your anxiety now?
I guess I'm back to a 5, maybe a 4.
Okay. Can you touch it with
Alright.
Can you touch it with your whole hand? Or what's the next thing you think you can do?
I don't know. That was enough. I don't want to do anymore.
Okay. Let's try it. You're doing really good. And remember when you did it with one finger and it was easier than you thought?
Yeah.
You're doing really good.
Thank you.
And just think about, it's just hard work. You know what? It's not really fun for me either because it wants to touch our shoe.
Mm-hmm.
But think about what you're doing. You're really doing a good job of trying to fight your OCD.
Yeah.
And think about all the good things you're going to be able to do once your OCD is better. All the ways that it gets in the way. So, can you do it with 3 fingers then?
Sure.
Okay, let's try 3 fingers. I'll do it too. Okay, let's count to 10. 2, 3, 4, 5, 6, 7, 8, 9, 10. Can you keep going?
Yeah, it's not so bad.
Okay, how long can you keep going? You count.
11, 12, 13, 14. This isn't too bad.
Good. Where's your anxiety right now?
It might be coming down, maybe like 4, 3.
Wow, you're good at this. You're doing a really good job. That's fantastic. Wait, let's see. No, I don't think you didn't explode, did you?
No.
Good job. Let's try it with your whole hand. I'll do it first too. I'm doing it too.
Alright.
Excellent. Good job. That's really great. Good. Is this harder or easier or about the same?
Yeah, it's harder because I'm like closer to the bottom and that's where it's all dirty and gross.
Okay, good. So what's the next thing that we can, you graduated from the top, man. You did great.
Yeah.
What's the next thing we can do that maybe is a little bit
My shoe's
harder?
not too dirty. The bottom's like,
Okay.
germs and gum and stuff.
How close can you get your finger to the bottom? Like, see what I'm doing? Can you go that close?
Like as close as I am right now.
Okay. Okay, so just hold it right there. Where's your anxiety right now?
It's getting bad.
Okay.
It's getting closer. I'm getting freaked out.
Have you ever touched the bottom of your shoe?
Maybe putting it on
And what happens?
accidentally. I just don't like it.
But you're able to tolerate?
I mean, I don't like it. I did it, but
Yeah.
kind of had to.
But there's a difference between doing something you don't like and not being able to do something, right?
It's true.
And think about, would it be important for you to be able to do things that your OCD is getting in the way of?
Yeah, I mean, I got to put my shoes on.
Yeah, you got to. So even though you may not like it, what bad thing do you think is going to happen?
Well, I think I'm going to get sick and I'm going to die because it's all gross and there's millions and
How many
billions
times?
of germs.
How many times have you gotten sick from touching the bottom of your shoe? Because you said you've done it accidentally sometimes.
I don't know. I was sick. I don't know if that's why though.
What do you think? Have you ever gotten sick without touching the bottom of your shoe?
Yeah.
People get sick all the time, right?
Yeah.
It's going to happen to us. You're probably going to get sick again in the future, right?
Probably.
Okay. Can you get closer? Think about how good you're doing, how strong you've been, and what a great job you've done. You touching it? I can't tell.
No.
Okay.
Not yet. No.
Okay. But see how good you're doing? Just think, even for like 5 minutes ago, you could barely even do like one finger. Now you're doing this.
That's true. Yeah.
That's good. What part of the bottom of your shoe is the least dirty? How about the edge? How about like there?
Yeah.
Nothing ever
that doesn't
touches.
really touch the bottom.
Nothing ever touches the
Yeah.
edge. Let's try that. I'll do it too.
Oh, you're touching.
Yeah, let's touch.
Touch
You
it.
can. Yeah, you can touch it. Go ahead. Just. Good press, man. That's a hard touch.
Yeah.
Good job. That's really great. Excellent. So, how you doing with that?
I'm doing okay.
What's your anxiety?
It's like a 7. I'm getting close.
So this is a
to
little.
where it's bad.
This is a little bit harder. Yeah, it is harder. But think how well you're working your way up.
Mhm.
You're doing a really. Ooh, I saw you sneak down to the bottom there. Extra credit. Excellent. Good job.
Look like a clean spot.
Yeah, that's really good. You're doing great. So we'll just kind of sit here for a little bit and we'll see how it goes.
All right.
I think you're doing great. What do you think about this?
It's fun.
It's kind of fun, isn't it? kind of silly. Good. Can you move it slightly down a little bit? See, like what I did, just a little bit like that.
No, I don't like that.
Okay. So maybe that's a little bit too hard. We'll just wait. Where's your anxiety now?
It's better now that I'm not touching it.
But right before you stopped touching it, where was it?
It was about the same. It was like getting to an 8, and then I was just like, no, I'm not touching it
Yeah,
anymore.
because that's a little bit harder. And I mean, your OCD is really fighting back, isn't it? Because it's not, your OCD is not used to being frustrated.
No, I just don't do it. And
You
then
just,
I'm okay.
yeah, you just give in it, okay. So you're kind of pushing back. I mean, sometimes we think about OCD like a bully.
Yeah.
Like the always bugging you or trying to steal your lunch money or whatever. And so it doesn't like it when you don't give in.
Yeah.
So, but
Can I go wash my hands?
no, let's just wait a little bit longer, okay?
Okay. I got pretty close to the grossness.
Yeah. Well, but you did really good. You really started very well. You're doing like a great job of this. So, what else can we touch? Let's think of something.
Nothing.
You good for now? How about you with the other hand? How about the top of your shoe with the other hand?
Which hand? This one?
Yeah, you can do it with the other hand.
Yeah, this part's all right.
Okay,
Do
good.
that.
Are you doing anything right now to make the anxiety go down, like in telling yourself anything or thinking anything?
Well, I know that my shoes aren't too dirty, so I know that that's okay.
Okay, good. Could you touch the top of my shoe?
They look really dirty and smelly.
Yeah, I don't know.
All right.
I'll touch yours and you touch mine. Okay, ready? 1, 2, 3. Where's your anxiety now?
It was like 7.
Okay.
It was like as bad as the bottom of my shoe.
Okay. Yeah, I'm not really sure where these have been, so we'll. Anyway, we could go on and on and on with this, but was that give you a good sense of how we would do this, and how we're maintaining the exposure, and as your anxiety comes down, we kind of go to the next step. So that was like 5 or 6 steps just to get one finger to here. And I mean, we didn't even get to like rubbing the ground, touching the shoe and doing your face, doing this, sticking your finger in your mouth. And then the coffee cup would be touching this to the point where you put your hand in the coffee cup and rub it on your face. I mean, whatever you need to do, I mean, to work up. And that's how you would work through an exposure. And pushing, I mean, did you feel that I was that I was pushing you too hard or giving you?
No, I think that when I showed signs of being nervous or heightened anxiety, you were kind of, okay, let's take a step back. Let's not push, when you're ready.
Right, right. So it's basically working at the kid's own speed. The exposure should be whatever the child thinks they can do plus 1, right? Plus 1%. So you want to continue to kind of push, but you don't, if I'd said, no, I want you to put your hand on this right now and hold it there no matter what, you probably wouldn't come back next week.
Shut down. And
yeah, you'd shut down.
You'd
So you
lost
can't push. But as you develop a better relationship with the child, so this could have been a first session. This would be a great exposure for a first session. As you develop the relationship and as you get more experience, then I'm going to push a little bit harder. And really try to move along. So let's give Pete a hand. Good job. So there are any no limit to the number and the types of exposures that you can do. I mean, the tapping you had brought up earlier, would be, can you tap on this side without tapping on the other side? Is an example. Or sometimes it might be we can't prevent doing the exposure because it's too difficult. Okay. How quickly do you need to tap? I mean, do you need to do it right away? Absolutely right away. So why don't you do this, and let's see if you can go 5 seconds without tapping on the other side. We might use like a shaping procedure almost to gradually extend. If kids have to walk in a certain pattern, just mess up the pattern. Kids that have to do things in groups of 3s, what would be harder for you to do 3 times? You got to do it in groups. What would be harder for you to do it 4 times, or 2 times? Or to do 1, 2, if you do 1, 2, and then 3, does that satisfy it, or is that a little bit harder? So with the kids, it's just, and like what I did with Pete, like, what do you think you can do? What's the starting point? The goal is whatever your OCD tells you to do, I want you to do the opposite, to not give in to your OCD. Where's the starting point? What would be the best way? So if some kids have a really complex tic, what would be a good starting point? So if OCD is telling you to do this, what would be the opposite thing for you to do? How can you frustrate your OCD? Kids that have to reread. Well, I would basically have to keep reading, or I would have to stop and shut the book, or I would have to read it slower or faster. I mean, they know, the kids know what it is that they need to do. So you really work with them to help shape the exposures and shape the starting points. And then you can use your intuition and your observation to try to suggest, once you kind of get a sense of this, well, how about this? Or could you do this? Or could we make it more difficult? And kind of work that way. But it's truly a very collaborative effort. As the therapist, you want to have a pretty good sense of the kid's symptoms, and before the session to come up with like what you think might be a good starting point. Again, something concrete like, the contamination, touching stuff is good. We might have had touching, could you touch my pen? Could you hold my pen for contamination? Could you touch the ground? Could you touch the top of my desk? Is there anything here that you could touch? What would that be? So I was going to do the coffee, but he said that was too hard. So I said, what else could you touch? And he said his shoe. So that's fine. Doesn't matter what it is. We'll work up to the coffee another day, or maybe we won't do the coffee if we can get past it. But it's really kind of a creative, interactive effort, and you really work with the kid. The kid should also help inform the exposures. But you want to have some reasonable sense of what it might look like, and then to push. For the younger kids, the question you had asked earlier, we really do this in the context of play. I mean, there's not much C in the CBT. It's really more B. It's almost all B, because you're not going to. Sometimes you can explain to the kids, depending on their age, you can talk to them about understanding the OCD, or it's like a bully. The bully. And I didn't really clarify your age, so I was kind of bouncing around. If you were older, we could have had a more substantial talk. If you were younger, we could have had some more fun with some of the metaphors. 27. Yeah, right. So I figured I figured the bully might not have been too good unless you. With the younger kids, you might do a little bit of the cognitive, like OCD is kind of like a mean bully, or something like that. So then you could say, let's get back at that bully. Let's make a game. How can we make the bully mad? And I know, let's punch him or hit him or something. So we kind of do some play stuff like that. Or you would just say, let's play a game. Whoever, put like pennies on the ground. Whoever touches the penny first gets it for contamination. And then you have to put your whole hand on it, almost like Simon Says, or playing games like that. Or with contamination or arranging stuff. You can make the biggest mess first, and then we get a sticker. You do it in the context of play with the child, in a sense. There are any number of different kinds of exposures that we can do. So reading, kids that have kids that have to reread certain things, as I said. I want you to read the sentence and then close the book. What's the thing that you think you could do first? Well, I think I could read, like, since it would be hard, I could read a word. Okay, I want you to read the word and then close the book before you can read it again. Then I'll think it. Okay, I want you to close it and then go la 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 for 10 seconds so you don't have the chance to read it. Or I want you to read it backward. Or counting, people have to do things in groups of 3s. I want you to do it in a group of 2 or a group of 4. Some other kinds of exposures that we do, obviously messing things up is pretty straightforward. Throwing things away for kids that hoard. For younger kids, we'll have them bring stuff in and ask them to throw it away in session. I want you to bring in 3. What's the thing you think you could throw away the easiest? Maybe a couple of old envelopes or something. Well, I want you to bring those in to session, and then we're going to throw one away during the session, and then we'll do it that way together. We have family. Parents will bring in like laundry items, dirty laundry items, or clothes, or things that they can't contaminate because of schoolwork or different things. If they need to writing neat, we'll have them bring in homework. And the kids will do the homework in session. We'll say, I want you to purposefully make a mistake in the homework, whatever it might be. What are other kinds of symptoms that people have come across? I'm trying to think of other kinds of exposures that we'll do. For the need to confess or tell, we'll leave the child in the therapy room and say, I want you to draw on the wall, or on the chair, or on the table. Just do something, some little thing, whatever it is. And I'm going to come back in and you can't tell me what it is that you did. And then so that would be an exposure. With
Hoarding.
What's that?
Hoarding things.
Yeah, so hoarding things, we'll say, so we want them to throw something away. It would be the response mentioned, I want you to bring something in and throw it away, and we'll talk about different things that they can throw away.
So bring one of the things they've collected.
They're collected, right. So maybe they'll bring in like old homework assignments or
a dog.
Something like that. What's that?
A dog.
Yeah, throw away the dog.
Animal hoarders.
Yeah, right. I had a girl that I did a consultation on that the hoarding was so bad that she had like a little pet animal, like a little something that ran on a wheel, and it died, and they buried it in the backyard, and she dug it up and brought it back into her room. Yeah, that was pretty intense. Let's see, I'm trying to look. So showering, for example, or cleaning rituals, you want to basically, if somebody has like 4-hour showers, we might say, can you do a 3.5-hour shower? We'll break it down a little bit at a time. Or everything has to be perfect. Can you mess up your hair? Can you pick like one piece of hair up, and then we'll go walk around the clinic? Or let's button your shirt kind of crooked. That also you do kind of similar to what you might do for social anxiety kinds of things. The bedtime rituals. If mom has to do 6 things as the bedtime ritual, she has to say good night, good night, good night. Then she has to kiss the kid 3 times, say I love you, I love you, I love you, and then close the door and open the door and close the door. We might say, pick one thing. What's the one thing we can change in that? Well, she only has to do the door 1 time. So she does everything else except she has to do the door 1 time. And then we'll gradually we'll fade that down. I'm trying to think if there's some other. So anyway, there's all sorts of different kinds of exposures that you can do. We want to, but you really want to be collaborative with the kid, and you want to work on the kid. So sometimes we'll let the child pick, where do you want to start, which one do you want to do? And sometimes the child will say they want to do the hardest one. And we'll say, well, that might be a little bit difficult. Let's start with something a little bit easier. If the child says they really want to do the hardest one, we can say, well, we'll give it a shot, but you know what, it might be too hard. So if you really want to do this one and you think you can do it, let's try, but it might not work. Okay, just to let you know, it might not work. So, but we'll try, and then if it doesn't work, we'll pick something else. And that gets to the other point. When we're doing the exposures, before we start, we're going to say something like, so we have this list of all the symptoms, and sometimes when you write down how hard you think something's going to be, sometimes it might be harder, sometimes it might be easier. So you might say that the schoolwork, looking for the closed letters on your schoolwork, to make sure all the letters closed, you say that's a 3, but you know what? When we actually try to do that, that might be like a 6, and it might be harder. Or it might be really easy. It might only be like a 1. So we're not going to know until we try, okay? So just be aware that the first few things we do, we might need, for an older kid, we say, it's going to be kind of like trial and error till we find the right one. So you want to inoculate them against the possibility of failure so that if they can't do it, like if you weren't able to touch anything, and you just say, I can't do it, anything, we say, as a therapist, I would say, okay, you know what, I think I picked something a little bit too difficult. And I'm really sorry. The fact that you tried is so great. I'm so proud of you for trying this, but I picked something that was too hard, and I'm really sorry about that. So I'm going to have to do a better job at trying to find something that works better for you. You know what I mean? So you didn't fail. You tried. You did great. But we just didn't pick the right symptom. So the kid can never fail. You guys all use reframing. You always got to reframe it. And I mean, if the kid comes in and says, screw you and your damn OCD clinic, I hate this, and breaks your lamp and runs out, you're probably not going to reframe that. But I mean, short of that. Let's talk about the cognitive piece, because people did bring that up. So we've already talked about some of these things. So the main thing we want to do is we want to externalize the OCD. So you think about automatic thoughts. You guys all know about automatic thoughts that just kind of pop into your head. And so OCD, like shoe contaminated, head will explode. That's not a conscious, that may be a conscious thought for you, but it's triggered and it unfolds. And it's not something that you really put a lot of energy into monitoring or trying to dispute. We want to turn automatic thoughts into not automatic thoughts, or automatic reactions into not automatic reactions. And what we do is we externalize. So whenever you have an obsession, you want to recognize that as OCD and relabel it. I won't get sick if I touch this, it's just my OCD talking. I won't get sick if I touch my shoe, it's my OCD. I may not be strong enough to touch my shoe. My OCD is really strong. I still can't touch my shoe, but I'm starting to recognize that I can't touch it because my OCD is trying to tell me that it's contaminated rather than this is really dirty and contaminated. Just putting that little extra level of piece of separation in. We want the kids to start that right off the bat and kind of work with that and kind of continue that throughout therapy. I already talked about this. I'll actually share this with the older kids. Say, everybody has thoughts just like yours, but the difference is how we react to them. To most people, it's just like the radio on in the background, but to you, it's really more interrupting you. So it's not that you're crazy or that these are really bizarre, weird things. It's just the fact that you are more sensitive to them, because people with anxiety are more sensitive to what's going on around them, and they tend to be more fearful of things that other people might not be as afraid of. So we talk about reality testing. We talk about challenging irrational beliefs. So the person that has this crooked, because afraid that her mom is going to die or his mom is going to die, I might talk to myself like, how realistic is that? Do you really think that's going to happen? How might that work? What's the mechanism by which that might happen? So you're afraid of it, and that's a real fear, and I certainly understand that. But on some level, you know that really is kind of an impossibility. Or the kids say, well, I know that it's not really going to happen. I know that it won't happen, or that what they'll say is like, I know that it probably won't happen. And so then we might try to challenge these beliefs. Well, what do you think the chances are of it happening? 1 in 100, 1 in 1,000, 1 in a million? What do you think the chances of it really are happening? And try to get a number from them. And then you can say, oh, really? So that's a pretty rare event. And on what basis do you think? So 1 out of 1,000,000 times that this is left like this, that will directly cause something bad to happen to your mother. What's the mechanism for that? How do you think that will work? Well, I mean, I know it's not really going to I know it's impossible for it to happen, but I still feel really anxious. Right, it's your anxiety, it's your OCD, it's these thoughts that are making you feel this way. It's not a real danger that this is going to happen. Again, trying to separate kind of the thoughts from the behaviors. So now that we've acknowledged that this fear is coming from your OCD, we can try to address it through working with the OCD. So I do that some, especially with thoughts that are like in the future, like you were talking about with the cancer. So I had a boy that was afraid of getting contaminated by using the bathroom at his school, and he wouldn't use the bathroom at his school because he was afraid of germs, and he actually wouldn't. So he stopped drinking. I mean, he wouldn't drink anything during the morning or the day of school because he was afraid he'd have to go pee, and then stopped eating because then he might have to go to the bathroom too, and so he was like falling asleep in school. And so talked about the fact that, bathrooms are gross, and there are germs, and there are dirt at bathrooms. But so your high school has 2,000 kids at your high school, and say there are like 4 bathrooms. So there are 500 kids per bathroom, and each kid may use a bathroom maybe a couple times a day. So there are 1,000 bathroom trips a day at your school, let's say. And how many kids got sick from using the bathroom yesterday? How many people died from using the bathroom yesterday? Well, no one. So there's less than a 1 in 1,000 chance that you're going to die from using the bathroom on any given day. How about the last week? How about the last month? How about the last year? How about the last 10 years? How about the last 20 years? So over the last 20 years, nobody at your school has died from using the bathroom. So let's multiply that out. That's 4,000 days times 1,000 bathroom trips. That's 4 million. There's less than a 1 in 4 million chance that somebody's going to die. And do you think anybody's ever died from using the bathroom, directly from using the bathroom? No. So there's a 0 chance that anybody will die. What about getting really sick and having to go to the hospital? Probably not. What about getting kind of sick? So you can kind of use this logic. So there really is a very limited chance that anything like this will happen. Yeah, you might get germs from using the bathroom at school. Those are going to be any different from having somebody cough in class, or from walking down the street, or from eating dinner at your dinner table? Probably not. Can you avoid all these things? You really can't. And so what if you get a little sick? What's the worst thing that can happen? Have you ever gotten sick before? And what happened? Did your head explode? And again, you don't want to do it in a hurt. This is all done in a collaborative manner. Being sensitive to these kids, this is real fear. I mean, this is real to them on some level. So you really want to kind of work with these cognitive strategies to try to really help them reality test. And the other thing that I think can be helpful is to do kind of this cost-benefit analysis. So there's a 1 in 4 million chance that you're going to get sick from using the bathroom at school. But you might get sick from using the bathroom at school. There are germs there. But let's see the cost to you of avoiding this very, very low probability of something happening that won't even be that bad. You get a little bit sick, you stay home from school for a day or whatever. So you're not eating, you're not drinking, you're skipping lunch, which is kind of the big social time during the day. You're falling asleep in class because you're not eating or drinking, and you stay up all night worried that you might need to use the bathroom, so you're really tired. You're flunking your classes, you feel really bad about this, your friends are thinking you're kind of weird, your parents are all upset. That's a huge price to pay for avoiding the very rare chance that something not so bad might happen. What do you think about that? And really trying to kind of use some of these techniques. Now, we wouldn't do this in the middle of the exposure, like I said, but we would do this during either post-processing the exposure or maybe helping to set up the exposure, of getting them to really start challenging or thinking differently about some of their obsessions. And I've talked a little bit about some of these things. So we want to consider the objective data. So how many times? So out of the 3 times you did have to use the bathroom last year at school, how many times did you die? How many times did you get really sick? How many times did you actually stab your parent in response to those intrusive thoughts about you stabbing your parent? So by moving this, you can prevent your mom from dying. How many other things can you do? You know what? Let's see. This is, if you could cause a car to crash into a tree 20 miles away by moving this, you should really be able to move this paperclip an inch, because that's a lot lighter and it's a lot closer. So do you want to see if you can do that? Again, not in a condescending or negative way, but in the context of an appropriate relationship. Well, let's try and see. That's ridiculous. But is it any more ridiculous than this other thing? Let's see if we can do it. I'm going to try to do it with you. I'm not making fun. I'm trying to understand better your OCD. Let's see if we can do it together. Well, we couldn't do it. So what do you think actually about turning this to keep your mom from something bad happening from your mom? Well, I know it's just my OCD talking. That's right, it is. That's really good that you're able to recognize that. Let's work on, it's your OCD false alarm is going off. Let's see how we can fix that. And kind of focus on that stuff. And learning how to tolerate uncertainty. Sometimes bad stuff does happen, but what's the risk, the price that you're paying to avoid these things? And then, as I said, people are using more mindfulness-based approaches, so like labeling their emotions in the context of the exposures or after may be helpful in kids. It really hasn't been studied in any way. Or learning how to just kind of learn how to tolerate the anxiety. I feel really anxious right now. And rather than directly challenging the thoughts. And I think there's really no evidence in kids about the relative merits of some of these different, ACT or mindful-based approaches or not. But I think they're all probably pretty valid for different symptoms in different kids at different times. And something certainly, if you're familiar with some of these other strategies, would be something perhaps to try with certain kids. Okay, so how do we expose thoughts? How do we expose obsessions? Some kids will say, I have obsessive thoughts. I have these intrusive thoughts of wanting to stab my mother. We've had kids that have had that thought before. But there's no obsession. It's an obsession only. I mean, there's no ritual. There's an obsession only. There's no ritual. So I've rarely seen an obsession in the absence of some kind of a ritualistic behavior. And the ritualistic behavior is called avoidance. And DSM-5, I think, is actually going to be incorporating avoidance into the definition of OCD to reflect that fact. I don't go to my parents' house, or I don't go to whenever for an adult, when I'm at home, I avoid my dad. I don't go in the kitchen. I don't use a knife. Whenever I have this thought, I have to go back into my room and listen to music to make the thought go away, or repeatedly say over and over again, no, 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 no. Those are all would be considered compulsive behaviors. So when we're doing exposure and response prevention, the response we might want to be preventing is avoidance. We might want to be having the kids stay in the situation. So we would expose an obsessive thought the exact same way that we would expose a ritual. So you can see here from this list, we're going to make a hierarchy. So let's pick the thought of intrusive images of stabbing my father. Okay. So let's make a list in rank order. Which of these things would be the hardest for you to do? Imagining the thought, writing the thought, drawing a picture, saying the thought out loud, telling the therapist the thought, show my therapist a picture, have my therapist read the description, sing it, record it, whatever. You could probably have 100 different ways of doing this. Kabuki my thought, rap my thought, whatever it is. And then we're going to expose it in the same way. So imagine the thought. Okay, I want you to sit here in the chair, and I want you just to think the thought, to right now conjure up that image of you stabbing your father. And I want you to do it in detail, and I want you just to imagine it for we're going to do it for a minute. I'm going to time you. And you just keep imagining it over and over again in as much detail as you can. That's exposure. Okay, so now can you write the thought down? Write the image down. First I come into the kitchen, and my dad is there, and I get this urge that I want to stab him, and I see the knife drawer, and I'm really scared, and he's just sitting there. What's he doing? He's drinking coffee and reading the paper. Okay, and then I go over to the drawer, and I get the knife, and I pull out. Which knife do you pull out? I pull out the big one. Okay, does he see you? No, he's reading the paper. His back is to me. Okay, but does he hear you open the drawer or come into the room? No, because he's reading the paper. Okay, so you get the knife, and then I close the drawer, and I start walking towards him. Well, does he hear you walking toward him? Does he notice you? Well, no, because he's reading the paper. I say, you really must be a quiet walker. You sure? Yeah. And then I get over and I pick the knife up like that, and he's there, and I'm going to stab him, and then I stab him, and he falls over, and he's all upset, and there's blood, and everybody's screaming and freaking out, and then what happens? And then, blah, blah, blah. Okay, let's do it again. Let's do it again. More detail. I want more detail. I want you to describe everything that's happening, what you're thinking. How come he doesn't notice you're coming? Don't you think he would notice you coming if you're there in the kitchen? What is the kitchen like? Is he sitting in it? Which chair at the table is he sitting at? And where's the knife drawer? So are you going to be able to actually get the knife without him seeing you? Is your kitchen set up that way? How close is it? How far away is it? Is anybody else in the kitchen? What's going on? Is it after school, or is it in the morning? And what you tend to find is that these obsessions really are really inconsistent logically, typically. It's like a dream. You have a dream, and you're in this kind of a weird location that's kind of familiar but not really, and stuff happens, and it really may happen. If you stop and think about it, you say, that just makes no sense whatsoever. That's kind of like what these obsessions are like. So the more you press for detail, the more you push, oftentimes they collapse kind of under their own weight. Well, wait, so he couldn't, the drawer is in a place right next to where he's sitting, so he couldn't not see me. And so I guess maybe he saw me, but I ran fast to do it with this. And, well, your dad's a pretty big guy. Don't you think he'd be able to block you from doing it? Have you ever stabbed anything with a knife? It's pretty hard if you're going to stab somebody in the back to get the knife, and you'd have to press it pretty hard. What did it feel like going in? Well, I just, I don't know. It's easier not to have the obsession. So by doing the exposures, I mean, I'm simplifying a little bit, but that's kind of the process that we would use, and doing it over and over again. So what we'll do is we may record the obsession like an MP3 of the obsession, have them play it, of them describing it over and over again. And the analogy that I like to use is, think of the scariest movie. So, Scream, Saw, Freddy Krueger, whatever. And think of this scene where with the chainsaw and the axe and people are getting chopped up, the scariest. My kids call them pop-ups. When the scary thing happens in the movie, the person jumps out. So think of the scariest pop-up. And when you're watching that in the movie theater, like Paranormal Activity, everybody screams and jumps out of their shoes. That's really, I was scary to me. I brought my daughter. I was scared too. I didn't like that movie. It's scary. So now imagine getting that one scene, the one pop-up scene, the scariest scene, say 10 seconds, 5 seconds scene, putting it on a tape and recording it 100 times in a row and watching the tape. The first time you jump out of your shoes. The 5th time you might kind of jump out of your shoes. The 20th time you might say, this is really stupid. Why do the co-eds always go to the barn in the dark at midnight in their nightgowns when there's a murderer loose on the farm? This makes no sense. The 50th time, you'd probably be bored. And the 100th time, you'd probably be asleep. That's habituation. That's what we do when we expose these thoughts. And by having them talk it and write it and draw it and share it and listen to it and hear it and doing all these things, you're just exposing it and you're taking the emotional valence away from it. Again, the thought may be disturbing. Right now, if everybody close their eyes and imagine picking up a knife and stabbing through the heart the person next to you. It's kind of, yeah, okay. So, yeah, it was kind of creepy or kind of weird, right? But you're not going to do it and you're not going to react to it necessarily. I hope you aren't. If anybody is murdered tomorrow, it's not my fault, okay? Put that on the tape. You don't react to it. We can walk away and say, oh, this crazy guy's had this really funny thing to tell us, So, because it's the reaction. It's the reaction and it's the fear of losing control that really gives the heat to the obsession. So by exposing it to broad daylight and over again, we're kind of removing that element from it. So that's how we would deal with obsessions.
This might be a silly question, but as a therapist, if you have a person, like I'm thinking the adolescent in this case, who is having these obsessive, just very kind of dark thoughts in terms of hurting people in his dreams and his thoughts, he has these kind of what he describes as unwanted, just uncontrollable thoughts of him hurting someone. How do you distinguish that between this being an obsessive thought versus this being something else?
Psychosis or homicidal tendency. Well, that's an important point. I'm making this kind of fun and a little bit light now because you do want to have some flavor of that when you're doing. Again, you want to be sensitive to the child, but again, humor is the best antidote for anxiety. So when we're doing exposures, again, within the context and appropriate to the child's situation, you want to have fun. You want to have some energy and some positive energy, kind of making it like a game in some ways, because that's going to lessen the anxiety of it. When you're doing these kinds of exposures, again, you wouldn't do this the first week or the second or the third week. And you would do this in the context of very careful psychoeducation and very careful setup and a very clear explanation of the rationale for doing this. Because this is really hard stuff for a lot of kids. So you do need to do this in a sensitive manner with the kids. And that does come up because we do have a lot of kids, and it may be sometimes with teenagers, sometimes it's a differential of, is this kind of like a pre-psychotic behavior, a prodromal state? Are there other kinds? Are there drugs? Are there other kind of like antisocial or aggressive tendencies that we may be dealing with here? You need to do a very careful differential before you do something like this. So how unwanted are these thoughts? What are the likelihood that the kid is going to act on them? A kid with OCD that has these fears of killing their parents is probably not going to be covered with tattoos saying kill and death. Or listening to they're going to be avoiding everything that's going to trigger it. They're not going to be listening to death metal most likely. They're not going to be wearing black. They're not going to be having like spiked collars and hanging out with other kids that are doing this kind of stuff. So you do need to do a careful assessment that this is ego dystonic. It's unwanted. I don't want to do it. In order to avoid kind of making this happen. We had a boy in clinic who came in and presented with, he had intrusive images of killing his mother and killing his father and sleeping with his mother. And 2 minutes into the family session, we could completely understand where all these came from. So sometimes these do reflect. I mean, he had a very distant, negative father, and he had a high EE mother who was way over-involved but incredibly emotionally critical. So you could kind of see these behaviors. But we had to be very careful to see to what extent is this fueled by the... Clearly, I think most OCD symptoms are somewhat random in terms of the way they've developed, but it's very clear that in some cases, you can see that the specific symptoms are shaped somewhat by the child's context, the emotional or psychological or social context. So sometimes you can understand some of these symptoms. Sometimes they're completely random. But you do need to have an understanding of all these factors as you're doing the exposures, especially with these kinds of exposures. But even in the case of if somebody... I had a kid once that was terrified, was a teenage girl, she was babysitting, and she was terrified that she was going to sexually molest the babies that she was babysitting. And there was no, I mean, it was the farthest thing from reality. I mean, it was pretty clear, and she was horrified and really frightened. But she couldn't tell anybody. She was so embarrassed or thought she'd get in trouble, so she kept taking these babysitting jobs because she had no reason not to do it. So again, using this same kind of an approach, we were able to address these symptoms. And you do, I mean, sometimes you do things that might seem reasonably outlandish to do some of these things with sexual obsessions. I mean, you're going to do the same thing. You're going to write them down, say them. I'm going to tell them to you in all their detail, in all their glory. And because we have to go under the context that these thoughts have no meaning in a larger sense. They're kind of background noise and thoughts, and everybody within the last month has had an intrusive sexual thought, has had an intrusive homicidal thought, has had another intrusive crazy thought. I mean, it's just part of human nature. We may not even be aware of them, but any aspect of the human condition is fodder for what's going on in our brains. So we need to really communicate that the meaning of the thought isn't important. Not to downplay or to denigrate or dismiss the emotional reaction to the thought. We can't do that. We need to honor the kids that we're working with and their pain and their suffering, but it's not about the content of the thought. So we're going to use the same kind of thing, whatever these thoughts might be, to expose them and to try to eliminate their impact on the child's life. Was there another question?
We talked about pandas, and I've had a couple of mother clients, and I don't mean that in a bad sense, but they just had a baby, and they'd had a real either exacerbation of or onset of really, really horrific, intrusive thoughts of hurting their babies. And I've heard that there can be like a postpartum anxiety that triggers this. Can you comment on that?
Yeah, so postpartum OCD or anxiety, so mothers that have just had right after pregnancy have a lot of intrusive thoughts. Yeah, it's a defined syndrome, postpartum OCD. And it's likely related to hormonal changes associated with pregnancy. But it's absolutely horrifying to the mothers that have it. I've never worked with the case because I work with kids and adolescents, but I mean there are cases in the literature of that are really, really very frightening. And again, the same kinds of treatment approaches. I don't know whether there would also be more of a psychopharmacologic or hormonal treatments, medications that might help with this, but but clearly, clearly it exists. And I don't know the treatment skill. I think.
John, I have two questions. With the example you gave with the stabbing of the father, do you think it would also be helpful to say what else could you do and kind of do a more positive response instead? I kind of use it as an opportunity to do a alternative way of dealing with the dad. I guess I'm just wondering, because because right now you're going through that, but I guess I guess I would be wondering, we talk, and I always talk about the core fear, what's the core problem, and I guess, although you can take the content of the thought, there must be, I would assume that there might be things going on, whether it be, things.
In the relationship, you mean?
Time to get into
Yeah,
the context,
yeah.
Things like that, so I guess.
Yeah,
I'm
this-
wondering, I know that you have to go.
Right. I'm just kind of doing the technique. Yeah, I mean, you certainly would want to consider all this stuff in the broader context of what's going on in the relationships and other symptoms and all. And we do, we would address that. I think so. If there are issues in the relationship, which sometimes there are, sometimes there aren't, we would want to address that. We also, you also would want to teach, we want to teach these kids problem solving and coping strategies.
You would cut that off, you might stop that and say, okay, instead of doing this, let's think of it something else now. Kind of use it as I guess I'm just wondering, would you cut the exposure and maybe?
We would, well, I think we would want to do the exposure because if we the model would kind of considers, when we're thinking about these obsessions, we're kind of thinking about this is your, in terms of the OCD, these are kind of normal thoughts gone awry in some sense because of the way that you react to them. And we want to try to change the reaction to the thoughts. So again, thoughts like these are reasonably normative, but it's the fact that they're blown out of proportion by the kids for whatever reason. So we do, kind of consistent with that model, we would want to change the child's reaction by kind of normalizing the thoughts and reducing the emotional valence of them. So I think the exposure piece is something that we would probably want to try to do. But in addition, we might also want to teach the kids other kinds of strategies for dealing with things that we think would be relevant or important to the thoughts, either in terms of the relationship or how to manage anxiety or how to manage the triggers to these thoughts in certain ways through different kinds of techniques. So I don't know if that answers your question or not.
I mean, it's really interesting to try to figure out how, whether or not, if you would do a latent and class analysis of obsessions and whether or not there are underlying things that cut across some of these things.
Yeah.
I mean, whether it be relationship with dads, and, you know what I'm saying?
Yeah, no, I think that would be
Because, because there must be more underlying that obsession.
Well, it is interesting. The other thing, too, when you think about kind of underlying things, I mean, again, I kind of look at it like a big ball. OCD is a big ball of OCD, and I think I used an analogy earlier. We're kind of chipping away at the ball. So every symptom we address in every context should help to address whatever the underlying process is. So it may be to the point when we actually get to these obsessions that we would, that there would be less to work with, than when we first started with, because we've actually started to kind of shrink this ball. And then the other thing is that you may be referring somewhat to is it's also careful to have a clear understanding of the symptom, because this symptom may or may not be OCD related. I mean, I'm talking about something that's like an ego dystonic, unwanted, unrealistic fear that isn't really grounded in factors that might make you want to think about a different way of approaching it. In the sense that it's kind of a random fear that the child has that we would do with exposure. If it does reflect situations in the child's life or other kinds of fears or other kinds of processes, then we certainly would want to deal with those either in addition to or instead of doing the exposures. So again, this is just kind of a rehash a little bit of what we've talked about. Changing the emotional valence. We've had kids sing their exposures. I want you to write a song about your exposure. Again, to change the valence and to kind of make it silly rather than real. And we might want to have them postpone, like with GAD, you schedule worry times So we may want to do that sometimes. So you're only allowed to like worry or kind of have these thoughts if you can. But the problem with that for obsessions is you don't want to have them suppressed. The worst thing you can do is ask them to suppress the obsession, the thought. Just try to ignore it or try to make it go away. That's not what we want to do. Instead of pushing stuff off or avoiding, and this might be something relevant to what you're saying, the worst thing you can do if you have this intrusive thought or frightening thought or an obsession is to try to push it away or ignore it, because all you're doing is reifying the fear. You're not challenging the validity of the fear. We want the kids to challenge the validity of these fears, at least as they're conceptualized. Yeah, you might be able to get sick if you touch germy things. You should wash your hands. But the fact that if I touch the bottom of my shoe like this, my head is going to explode, is not a valid thought. And so we don't want people to suppress or ignore those. With OCD, you want to bring everything into the light of day. Because just like the mummy, when it's bring into the light of day, most likely it will crumble because a lot of it is patently unrealistic. With other anxiety disorders, there's typically more of a kernel, some kind of a kernel of I think in some senses, there may be more of an exaggeration of more kind of realistic situations that you might see, which would argue for a different interpretation or a different response. But for OCD, a lot of the symptoms are more patently illogical, and so you really want to try to push the validity or challenge the validity of the symptoms. And as I said, I wanted to talk about one more thing. So with the little kids, we had a great case in our clinic of a little boy that had OCD, and he had a number of different symptoms. One of the symptoms was he had sexual feelings towards his teacher. I think he was 5. He didn't know what sex was. He didn't really know what sexual feelings are, but he had something and he assumed that's what it was. And he knew that they bothered him. I mean, it was ego dystonic. These were kind of unwanted things, and he was feeling bad about it, among other symptoms. So what we did for him, since this was in the context of play that we were going to address these symptoms, to deal with the symptoms initially, he had contamination fears that were the first things we started with. We got a big piece of butcher paper, and we outlined his body, and then we got another piece of butcher paper. We had him draw his OCD. And he drew like a big, ugly, giant ball with scars and hairs and warts and whatever 5-year-old kids do about their OCD. Make it like the meanest, ugliest thing you can. And it was a big picture. And as we would do the exposures, and as he would get stronger, we had him, every week he'd come in and he'd draw his OCD again. And it would get smaller, and he'd put Band-Aids on it and things. And it was a really nice kind of a metaphor about how he's getting stronger. In the first place, the ball was as big as the outline of his body, and then every week it kind of shrunk, smaller and smaller. Is a really way of demonstrating. It's a very concrete way. We're going to fight your OCD and shrink your OCD. There's no more concrete way of doing that than having him draw pictures of his OCD and watching them get smaller. Now, you wouldn't do this in the absence of doing exposures and other things, but for a kid that age, it was a nice kind of a graphic. The other thing we did, and the therapist that came up with this was great. He wanted to like beat his OCD up, so they would crinkle up paper, like make balls of paper, and throw it at the OCD like during session or part of the session, and treat it like make bombs. And he hated, what did he hate? I think he hated like artichokes or something. Some food that the thing he hated the most in the world. So they would draw artichokes on the paper and then crumple them up and make artichoke bombs and bomb the OCD with artichoke bombs, because that was the worst, most deadly, poisonous thing that this kid could think of. And they had a blast. I mean, he loved coming into therapy. So they would do the contamination stuff, and touch this or that, and just in the context of just doing it. And then they would bomb. They would say, this is really making the OCD mad. Now we need to bring out the heavy guns. And then they would bomb the OCD monster with artichoke bombs, which was really great. The other thing that the therapist did was to expose the sexual thoughts about the teacher, again, not knowing what sex was really, is they would talk about those, and he would kind of write some of this stuff out, and then they would bring in pictures of the teacher. And we exposed him to pictures of the teacher. And he would, and over time he kind of gradually got a little more comfortable with that, and it made it, he was able to get over that symptom. And we've had kids in clinic that have actually, if they've had kind of a similar kind of an unwanted ego dystonic attraction, or what they felt was kind of a symptom like that. We've had marriages in therapy where they married the object of their concerns, and we had like a whole ceremony and rice and things like that. And again, if you do it in the right context, that it's this so silly and so goofy, you know, it's kind of the final step on the hierarchy, is to work your way up to something like that to really address these symptoms. So there's no shortage of imagination in terms of trying to do these things. And with little kids, we really do it in the context of games, a lot of art, and other kinds of more physical or concrete manifestations are ways that they can kind of challenge the OCD, which makes it kind of fun. As I talked about homework, so you want to do homework. Again, what's in session? So the exposures we do in session, then they go home and practice. If there's something that they can't do in session, like it's only related to their bedroom, for example, you know, things on their desk, then we'll practice it in session. We'll kind of do it in an analog fashion, or maybe we'll have them do it imaginally in session, and then they go home and they practice that at home. And then we use like forms like this. I think you have this form also, where you can kind of graph the exposures on the bottom, like we said, and then you can really fill in the top with the exposure instructions, how often, how long, and then ways to fight the OCD thought. So if we are doing any kind of cognitive strategies, we can put those on there as well, and those are kind of nice. And then reward program, we'll do rewards with the kids. And this is a nice little chart for really young kids, because every exposure they get a sticker, and then when they fill the card, they can trade it in. This isn't specific to OCD, but it's just something that's important for a lot of kids. And again, it's effort, not results.